Hello, everyone. Welcome back to our next Journal Club meeting for the 2023-2024 session. I'd like to begin this meeting with a brief introduction of what the Research Society and the Journal Club is and what they represent. So, the Research Society was founded in 2022 by Dr. Pramod Ingle, the Academic Dean of LTMMC. The main reasons behind the creation of the society was connecting students to research opportunities in LTMMC, as well as broadening their research perspectives. The Journal Club is just one of the avenues under the research cell, the others being the debate club, events, and workshops. The Journal Club focuses on providing opportunities to engage with medical literature and enhancing one's knowledge about research methodologies. During our bi-monthly meetings, a research cell member presents a research paper, which is followed by in-depth discussions about the topic with the presiding judge. For today's meeting, we have Dr. Kshitija Patkar, who is an associate professor in the Department of Physiology. We would like to take a moment to thank her for finding time to participate in this meeting. So thank you, ma'am. To give everyone a basic idea about the format of today's meeting, we will first have Radhika Mehta presenting the SLO, followed by two separate paper presentations by Dhruv Salunke and Urvashi Bharia. So we will start with the SLO, for which we have Radhika Mehta from third major MBBS. She's also the student secretary of the Student Research Cell, and she will be presenting the specific learning objective, which is bias in research studies. So Radhika, can you please switch on your camera?
Hello. Hi. All right. Hello, good evening. I am Radhika Mehta, and let's get started with bias and research studies. So with this SLO, I hope that you will be able to at least understand the importance of reducing bias in research and have some understanding about it. One thing is that you can never completely eliminate bias from research, and you'll understand this as we go ahead. We know what the word bias means. We've used the word. But what does it mean when it comes to research? If I have to put it in the simplest terms, then I can say it is any non-random error which leads to deviation from the truth. So if you've taken a look at what I've written on the slide, it says any systematic error in the determination of the association between the exposure and disease. So let's just go word by word. So what do I mean by systematic error? So let me first give you an example. Say if a scale is calibrated incorrectly and always reads 5 grams heavier, then every measurement it takes will be off by that amount. So it therefore affects the accuracy of your measurements. So what you can understand is that they are not random mistakes, but rather resulting from flaws in the measurement system itself. So in research, that could include faulty equipment, biased survey questions, or incorrect data entry methods. So why are systematic errors, that is biases, particularly problematic in research? That's because they can lead to incorrect conclusions. If not identified and corrected, they can suggest a relationship between variables that do not actually exist or even mask a real relationship. So I'll show an example soon that will convey exactly what I mean by incorrect conclusions. But now, coming to this next slide, where do biases normally occur? So biases can come in at any point of designing your study, collecting data, analyzing it, and even during publication. Can I have the next slide, please? Okay, so this is an example. So how does it affect healthcare? Now it's quite a bit to read, but basically it's trying to say that bias can cause an estimate of an association which can be larger or smaller than what the true association is. So it can either be, let's say there is an association or there's not an association. Let's say there's an association, then bias can basically say the association is higher or the association is lower, but there is an association. But in extreme cases, bias can cause a perceived association which is directly opposite of the true association. For example, prior to 1998, multiple observational studies demonstrated that hormone replacement therapy decreased risk of heart disease among postmenopausal women. So you would want, as a clinician back then, you would think that giving this treatment is actually beneficial because you are supported by that data. But then recent studies, which are rigorously designed to minimize bias, they found the opposite to be true. That in fact, giving this treatment promoted increased risk of heart disease. So you can understand why it's important. So this example runs quite at extreme, but you can understand the importance of reducing bias, and this is something you look out for in the papers you read. So we'll go through some biases now, so you're better oriented. Can I have the next slide, please? All right, so this just shows the major biases that can arise during clinical research, right from planning, implementation, analysis, and publication. So we'll be covering some of these ahead. Next slide, please. All right, so let's start with selection bias. So there are three other biases that have included under selection biases primarily, which I will talk about later. But let's just understand what this particular bias means. For that, I would like you to draw your attention to the image at the right. Now, let's say I'm trying to conduct a study in a population. Now, I cannot conduct it in the whole population. I cannot, if it's in the form of a question, it's not logically feasible for me to go and give a questionnaire to everybody. So I need to draw out a sample. Now, if I draw out a sample, then it has to be truly representative of the population. The sample and the population cannot be different. So look at the image. In the population, in the black dots, you see a number of people who don't have disease. The blue dots are the people who have disease but do not display any symptoms. And the ones with red dots are the people who have disease and the symptoms. And I've taken a sample, and now look at the sample. There is no representation of anybody who doesn't have a disease. And it actually shows that there are more people who have disease with the symptoms. And there's just one blue dot. But if you look at the population, that does not really look to be the case. So the study population may not be representative of the cases and controls in the general population. This is your selection bias. It occurs when the selection of subjects into a study leads to a result that is systematically different from the target population. Now, this can happen in observational studies where the selection of participants is at random, such as cohort studies, case control studies, cross-section studies. It can also occur in intervention studies or clinical trials if there is poor randomization. So can I have the next slide, please? All right. So how do you avoid this bias? So it is ensuring comparability between the groups. What do I mean when I say that? It refers to the principle that the groups being compared in a study should be like my case and my control, should be as similar as possible in all respects, except for the variable that I'm studying. This is to ensure that any differences observed are due to the variable being studied and not due to other factors. So yes, like I said, these are the studies that it can come up. Another example that I could give you would be health studies that recruit participants directly from clinics miss all those cases who don't attend those clinics or seek care during the study. Due to this, the sample and the target population may differ in significant ways, and that will limit your ability to generalize your findings. Can I have the next slide, please? All right, thank you. Now, this is one of the selection bias, which is incidence prevalence bias, which is also called the Niemann bias. Before I explain this bias, it's important if anybody does not know the meaning of incidence and prevalence. For this example, let me explain it this way. That incidents are all cases that arise in a given time period, all new cases. Prevalence is the total cases, old and new, at a particular time. So have a look at this image. All right. There's a cohort of 20 individuals with a follow-up from TO to T2. Now, during this follow-up, if you see, there are 4 individuals who developed a moderate disease. So the moderate disease are the ones in red. And there are 4 individuals who got a severe form of the same disease. The severe ones are the ones in green. So therefore, the true risk ratio between the risk of the severe disease and that of the moderate disease is 1. However, people with severe disease have a higher risk to die. And before the time T1, 2 individuals died. So you can see the yellow dot that displays death. Now let's say I'm doing a cross-section analysis at point T1. That's going to be my prevalence at that point. All right. So at that point, if you see, since 2 people have already died before, at T1 we perform a cross-section analysis, we get a prevalence ratio of severe versus moderate disease of 0.5. Because if you see at T1, we have 1 severe and 2 moderate. So this gives you a very inaccurate risk ratio, which is basically telling you the severity distribution of the disease within that group. Therefore, whenever possible, we should estimate the occurrence of a disease in terms of incidence, that is by counting all the cases that occur in a sample in a given time interval, rather than at a specific given time point. So this is what it is. Next slide, please. So this, how to avoid it? The selection process of cases and controls from the target population should be rigorously the same and should be independent from the exposure status. That the investigator should be blinded to the exposure status that is happening. So this can occur with almost any study design. Let's say another example. You're studying cardiac arrest. One only collects data on arrival at the emergency department. So you would miss all the patients who were declared dead on the scene, who may be systematically different from those who make it to the hospital. So I hope that example also helps you understand that. Okay, the next bias. Another thing I wanted to add was that you have to make sure you're using incident cases rather than prevalent cases if you didn't understand the how to avoid section. If you take away that point, that's enough. Now, coming to loss to follow-up bias. So if you look at this, it's basically if any study that tracks participants over time, such as a prospective cohort study, there's a chance that some participants may drop out or be lost for various reasons. They might move, they might lose interest, or even pass away. So this is what we call lost to follow up. Now here's where the bias comes in. If the people who are lost to follow up have different health outcomes compared to those who remain in the study, it can skew the results. This is because the final analysis of the study is based on the data from the participants who remained and not on the entire original group. So you can look at the example that I've given here. Let's say you have a prospective study. You want to determine the incidence rate of renal insufficiency in hypertensive and normotensive patients. So you can see for several years of follow-up, the hypertensive patients have been following up, but normotensive patients, they haven't. At some point, they have stopped following up. So loss to follow-up bias may distort the true risk of renal insufficiency in hypertensive versus normotensive patients. So another example, let's say we're studying the effect of a new drug on heart disease. If the people who drop out of the study are primarily those for whom the drug isn't working, maybe they are experiencing side effects or they're not seeing improvements, then the final results of the study will be biased towards showing that the drug is more effective than it actually is. This is because the data from the people for whom the drug didn't work isn't included in the final analysis. So loss to follow-up bias can potentially lead to overestimate or underestimate the true effect of the treatment or exposure being studied, which can ultimately impact the study's conclusions. So to avoid it is basically to ensure the controls or the other groups do not lose on following up. So you want to maintain those high follow-up rates. You want to enroll motivated subjects that might reduce the risk of loss to follow-up. And you want to make questionnaires easy to complete so there isn't much resistance to stay in the study. So types of studies, loss to follow-up is commonly found in cohort studies, clinical trials, and any research involving long-term participant involvement. Okay, can I have the next slide, please? Okay, now comes publication bias. So let's start with an example, which is a reboxetine study. I have linked it down below if you would like more information on it. So researchers conducted 7 studies on reboxetine, an antidepressant. One of these was positive and got published, while the 6 negative ones were left unpublished. So do you understand where I'm going with this? Another example here, you see, a pharmaceutical company selectively published studies showing positive results for their drug, while withholding trials that demonstrate its ineffectiveness or harmful effects. By publishing only favorable results, the company can manipulate the perception of the drug safety and efficacy, potentially endangering patients who are unaware of the withheld data. Can I please have the next slide? Thank you. So it's a type of selection bias that occurs when the studies published do not represent an unbiased sample of all the research conducted. So there could be many factors that could contribute to this, which could be the study size, the design, the quality, the funding, prestige, and it goes on. For example, I want to tell you why is this a selection bias? Because when you're doing a systematic review, all right, you are going to be collecting literature. Now, if only a small percentage in the systematic review, only a small percentage of studies have reported a negative effect, that could suggest a potential publication bias. But again, that is just us suspecting it. How do you detect it? So there's a funnel plot method with which you can expect to find it. So if you see a funnel shape, then there's no bias, and if there isn't, then there probably is some issue there. So for those of you who do not understand funnel plot, it is beyond the scope of this SLO for me to explain it to you. So I have linked a YouTube video at the end of the presentation, so you can have a look at it later. Can I have the next slide? All right. So talking about confounding bias. Let's have a look at this example, and then we'll explain the bias a little better. So there's a study on role of alcohol in the etiology of esophageal cancer. So you want to check, does alcohol have any link to esophageal cancer, any causative association, whatever. However, the confounding factor, which is smoking, is associated with the consumption of alcohol, and it's also an independent risk factor for esophageal cancer. Let's say I do not know the patient is smoking. I think that, so what the results I get have influence of not just alcohol, but also smoking. So a confounding factor is any factor that is linked to both the exposure and the outcome. So if you see effect of alcohol consumption is determined only if the influence of smoking is neutralized by matching. So I hope that helps. Next slide, please. All right. So here's this. Confounding bias arises when the observed association between an exposure, that is a risk factor or a treatment, and an outcome is distorted by the presence of a third variable. So in that example, smoking was a third variable, which is related to both the exposure and the outcome. And it is distributed unequally in the case and the control groups. So it will lead to an inaccurate association between alcohol and esophageal cancer because of the influence of smoking. So types of studies where confounding bias occurs, you can see there's observational studies and experimental studies where it can happen. Okay, can I have the next slide, please? So how would you avoid confounding bias? Number one is match participants based on potential confounders. And the second one is to stratify participants to control for confounding variables. So stratification is a method used during analysis phase of a study. In this method, you would divide your participants into different strata group based on the values of the confounding variable. For example, if age is a confounder, you might create strata for different age groups like 21 to 30, 31 to 40, and so on. And then you would analyze the effect of the treatment within each stratum separately. So you can see the effect of the treatment at each level of the confounder, which can give you a more accurate picture of the true effect of the treatment. So there is another statistical method that you can use. Again, this is beyond the scope of this SLO to explain it. I have linked a YouTube video at the end, and you can watch that. All right, can I have the next slide? All right, so what is confirmation bias? All right, so let's just have a look at this example and see if we can understand. So failure to entertain a new diagnosis in the face of an established diagnosis, or dismissal of laboratory results as spurious when they fail to support the favored diagnosis. So basically it occurs when researchers, they choose selectively to interpret or prioritize the data that aligns with their hypotheses or whatever preconceived notions that they had, and they will disregard or maybe contradict any evidence that is provided. So I've put some two cartoons here. Hopefully that might help you understand. So this guy asks him, how far did you get? And he says, I've got the conclusions, I just have to write the protocol. So he's already decided what I expect the study to show me, and he will probably steer the study that way. So can I have a next slide, please? So it can occur with almost all types of studies, all right? So how can you avoid it? So number one is blind data analysis. You have to conduct analysis without knowing prior of the expected outcomes so that you can reduce the influence of the preconceptions on data interpretations. I think that's pretty self-explanatory, but if there are any questions about it, you can ask later. So you can another thing is you can use subjective criteria. Again, you need to have clear criteria for evaluating the evidence and making decisions. So you do not let your subjective decision minimize the influence of the data. Again, there's another cartoon I found, which I hope helps put that point across. All right. Next slide, please. Okay. So we have recall bias. So it's again an error when participants do not remember previous events or experience accurately or omit details. I think that's in the name. It can be caused by differences in the accuracy or completeness of the recollections retrieved by study participants. Same point. Cases are more likely to recall certain events and controls when questioned about their past history. So, an example of that would be let's say if somebody has myocardial infarction and you want to basically there's a case and control and you're assessing risk factors for myocardial infarction. Cases are more likely to remember specific habits or behaviors related to it than the controls. So that's I think what that example, I mean that's what that statement is trying to say. Another example is a study. Yes, can I just go back to the previous slide? Sorry. Yeah. So study asks participants to recall their past behaviors such as smoking or diet, which may be influenced by their current health status. So they may inaccurately recall their past behavior because they might just forget. Maybe they want to, maybe there's a social desirability bias. They want to appear as they are following a healthy lifestyle and they do not want to recollect the past bad behaviors. And it can lead to biased estimates of the association between behaviors and health outcomes. Okay, next slide, please. Thank you. So, a good way to mitigate this bias would be just good interview skills, honestly. So, can I have the next slide, please? All right, interviewer bias. Okay. So, it's basically any difference between how the information is collected, recorded, interpreted by the interviewer. So, it's more likely when the disease status is known to the interviewer. So I would give you an example here. So there's a patient who has Burgess disease. He's enrolled in a case control study which attempts to retrospectively identify risk factors. If the interviewer is aware about the disease, he's more likely to interrogate extensively on the risk factors related to the disease, such as smoking. So he'll ask him, "Are you sure you didn't smoke before? Can you please take a moment and think about it again?" He's more likely to prod on with that particular patient than with the others because he's particularly aware in this case. Okay, can I have the next slide, please? So it can be minimized or eliminated if the interviewer is blinded to the outcome of the interest, or if the outcome of interest has not yet occurred, as in a prospective trial. Again, I think that is very self-explanatory. So it could be a double-blind study. So in a double-blind study, both the participants and the experimenters are blinded. This means that neither the participants nor the researchers conducting the experiment know what group the participants are in. So this helps to prevent bias in both the participants' behavior and the researchers' conduct of the experiment. So this kind of bias is mostly found in clinical trials. Okay, next slide. Okay, channeling bias. It's a selection bias in a way, and that occurs when certain treatments are preferentially prescribed to specific groups of patients, often based on their risk profile or expected outcomes. Now, this is just a way of example to explain it. So it's when you look at patients' prognostic factors or the degree of illness, and you choose that as a category to place your patients into specific study cohorts. So, for example, if you are in a study assessing the efficacy of a new antihypertensive drug, channeling bias might occur if patients with more severe hypertension are preferentially selected for the new drug. That will affect the outcome assessment. All right. Can I have the next slide, please? All right, so to avoid this, you have to assign patients to study cohorts using rigorous criteria. Use strict rules to decide which group each participant goes into, but most importantly, randomization. So the bias is more likely in non-randomized trials when patient assignment to groups is performed by medical personnel. Okay, next slide, please. All right, so these are just some biases out here, which it might be helpful to know about. Maybe in entrance exams they could come up. I will just briefly explain them. Number one is Berkesonian bias. It's another type of selection bias because of different hospital admission rates. All right. So let's give an example. If there's a study on salpingitis where the cases are selected from the hospitals, we may find a much higher association between salpingitis and IUCD than it actually is, because the hospitals are more likely to admit the cases with an IUCD than those who are on OCP. So this bias can be controlled by selecting cases and controls in appropriate settings, keeping in mind the study in question. Right? You can use random sampling, community-based surveys, so on. Now we have Hawthorne effect. It's basically it refers to the alteration of people's behavior when they become aware that they're being observed. So this change can be positive or negative depending on the research context. For example, people participating in a nutrition-related experiment may improve their diet solely because they're taking part in the experiment. So it's important to know that participants must be aware that they are under observation for this effect to occur. All right. So next we have the Gollum effect and the Pygmalion effect. So if you read both of them, they seem as if they're opposites. So Gollum is basically a blunted effect due to unmotivated researcher, and Pygmalion is an exaggerated response due to aggressive or highly motivated researcher. Let's say you are conducting a research and about some antihypertensive drug, and there are two researchers. One was unmotivated, the other one was really motivated. Now, for this research, he's going to measure the BP first thing in the morning. Then at some point in the day, he's going to give you the drug. And then again, he's going to measure your BP. This is the format. Now, the unmotivated researcher might sometimes measure the BP, sometimes might not measure the BP. But the highly motivated researcher, he's going to measure your BP every single day and at both the times. So when you have a researcher who is constantly checking your BP in this example, then the participants feel a little conscious about it. They want to see that the BP drops. So what they would do is they would introduce some lifestyle changes in themselves. They might exercise more, they might change their diet, and that could contribute to their BP reducing. And that could lead to an exaggerated response to the drug. So I think that should explain it. All right, so this is just a quick cartoon that I inserted just so you can understand biases a little better. So this is someone who's trying to, can anybody see it? I hope people can see it. So they want to look for a place for the upcoming company retreat. So this girl is trying to find that out. So she asks people at how to carry your desk plant brown bag, where they would want to go, and almost everybody says botanical gardens. And when she tells a friend that everybody wants to go there, then the thing is that it's a selection bias, because certain people are more likely to be in a sample than others. So it does not represent the whole group well. So you understand why everybody chose botanical gardens in this case. And she said it's pretty close because everybody I sit with at lunch loves plants. So then her friend says that I think you just stepped in the confirmation bias, where we process information by looking for information consistent with our existing beliefs. So then she plans to ask everybody, and she asks everybody likes botanical gardens, yes or no. And then in this case, it appears as a response bias because she has asked a leading question. So that does not accurately answer the main question. So I think that helps. Next slide. Yeah, thank you. And the slide after that contains all the articles I referred to for this SLO and also the YouTube links that I mentioned. So if you want to know a little bit more about what I said, you can obviously refer to these articles, and I think that will give you a good idea. So yes, thank you. And anybody has anything to say?
Thank you, Radhika. That was an amazing presentation, and you made it very simple to understand with your creative examples. I would request Kshitija ma'am to give her inputs on today's SLO.
Yeah, very nicely explained by Radhika with all those examples and cartoons. It was really very interesting. Very good.
Thank you, ma'am.
We will open the question answer round for the audience. So if anybody wants to ask questions to Radhika or Kshitija ma'am, you can please unmute your mics. Does anybody have any questions, or we'll move ahead? All right. So now for the paper discussion, we have two papers being discussed by two different presenters. First, we have Dhruv Salunke from first year MBBS, who will be presenting a cohort study on the elevated risk of life-threatening cataract in diabetic patients with retinopathy. So Dhruv, can you please switch on your camera?
Yes. Hello everyone, my name is Dhruv Salunke, and today I am going to present a cohort case study Its title goes as The Elevated Risk of Sight-Threatening Cataract in Diabetes with Retinopathy. So, first of all, what does it mean that it is a cohort study? A cohort study basically means that you take a group of individuals and you observe for changes that occur in them, and you measure them for a statistical analysis. So the study that we I am going to analyze today is uh, what is the association of diabetics who develop retinopathy, and how they are associated with that developing into sight threatening cataracts. So as we know that diabetes is a messy disorder and it leads to a lot of complication in cases of uncontrolled hyperglycemia. So this study will show how the development one of those developments is diabetic retinopathy, and how it is responsible for the increase in sight threatening cataracts. So first of all, to explain the background of the study, we'll refer to the past studies that have been done relevant to this topic, and what was in the mind of these researchers before conducting this study and why they thought that it was important. So first of all, the prevalence of cataract induced blindness was well established to be uh, occurring in people with diabetic retinopathy. We can see that in the general population, it was more than 35% individuals who suffered visual impairment. And then the pathophysiology, which explains this influence, is the prevalence of hyperglycemia in diabetes and insulin dysregulation. Another background that warrants the need for this study is the risk of cataract formation can be up to 5-folds in patients with DM compared to non-DM individuals. Okay, next slide, please. Okay, so the main objectives of this study that were considered was, first of all, the effect of diabetes mellitus developed diabetic retinopathy has already been well established in past studies to worsen ocular health. Obviously, diabetic retinopathy is itself an ocular disorder, but the association of diabetic retinopathy with sight-threatening cataract required further investigation, and that is the main objective of this study. Other than that, this study is not just focused upon this most important objective, but there are other objectives as a part of this multivariable analysis, and that is whether the duration of diabetes mellitus is a risk factor, and the existence of other comorbidities and other variables like gender, age, and even the medication that they are on. Are they also responsible for the occurrence of diabetic retinopathy to develop uh, cataract sight threatening? Okay, next slide, please. Yeah, to give you a brief information about the authors, this study was done in Taiwan in Chung-Shan Medical University. The main resources that were used for this study were from the Taiwan National Health Research Institutes. So basically, what they did was there is a database in Taiwan where all the insurance data of patients are recorded, and that was accessed by this institute in order to conduct their study. The study was from the year 2000 to 2016, and the software that they used to make the statistical analysis was the SAS version 9.4. Next slide, please. All right. So coming to the methodology, let's understand that how did the researchers conduct the study. So first of all, the institute LHID had a 2 million database from the year 2000 to 2016, and this they divided it into two parts. First, people who were diagnosed with diabetes mellitus and people who did not have diabetes mellitus. And what we want to do with these two individuals is that we are studying for diabetic retinopathy, right? So we will make a main study group, which is the study group of diabetic retinopathy, a study of people who do not have diabetic retinopathy. Now that can be two types of individual, right? People who do not have diabetic retinopathy can also have diabetes mellitus and not have diabetes mellitus. That is why we have one study group, which is the main individuals with diabetic retinopathy, which was 3,551, and the people without diabetic retinopathy but with diabetes mellitus, which the counts goes to 91,213, and the individuals who did not have diabetes mellitus were the second control group. So one study group and two control groups. Now, after classifying and making these three groups, uh, there were certain tests conducted for basically seeing the association of certain variables that were measured. So if we see, I'll not go into depths of these, but I'll just name them. First, one of them was the chi-square test, and there was the independent t-test. These were used to uh, these were used in matchmaking of the study groups when they were classified. After being classified into these three groups, they were also matched with respect to their uh, gender and with respect to their gender and their age in a ratio of 4:1. So you have the diabetic retinopathy study group, and in both the other control groups, we'll refer to them as DM group and non-DM group. So in a DM group, suppose there are four individuals. Uh, if and is in the DR group, one of them is matched to four DM, one DR patient is matched to four DM patients, and the same individual is matched to four other non-DM patients, and they are classified with respect to their age and their gender. All right, next slide, please. Yeah. So the inclusion and exclusion criterias for the three groups. So to for a patient to be compatible inside the DR study group, there has to be a confirmed diagnosis of diabetic retinopathy. The patient should have a scheduled fundus photography before being diagnosed with DR, so that they so that it is uh, made sure that the patient did not have diabetic retinopathy for a long time. And we have and the patient should be scheduled with optical coherence tomography before being diagnosed with DR. This is similar to the earlier point. And the DM control group, it included patients majorly with the history of type 2 diabetes mellitus. And how was this diagnosis confirmed? They used a blood glucose test, a HbA1c test, a OGTT test uh, for the diagnosis. And the diagnosis was confirmed by an internal medicine or a family medicine physician. Yeah, and for the when we are going to select the patients with diabetic retinopathy, some things that have to be excluded, some patients that need to be excluded, uh, were excluded on the basis of this exclusion criteria. First, in if they have legal blindness, if they have eyeball removal, ocular tumors, and if they have received cataract surgery, uh, if there is diagnosis of DR prior to DM, that I already told in the inclusion criteria. Yeah. So that way we have three study groups now: a DR group, which is the main study group, a DM group without DR, and a non-DM group. Next slide, please. Yeah, so after this patient selection, what the researchers did is that they used certain tools that we'll require to produce the statistical analysis. So that was mainly done using the SAS 9.4 version software. But what were these tools and statistical tools that we obtained from that? So first of all, the main thing that the researchers conducted was a Cox regression, was Cox hazard proportional regression. So I'll not go into the depths of it, but I'll explain its components. So when you read this particular slide, all the terms that have been mentioned here, if you just understand these and their indication, you will be able to understand the actual evidence that will be produced at the end of the study. So first of all, the p-value. Okay, so the p-value is a extensively used statistical number that is applicable in our case also. P-value indicates the association of a variable with your set outcome. So in our case, our variables are the main variable is the presence of diabetes mellitus and diabetic retinopathy and other comorbidities that are mentioned in the objectives. So this number will indicate the association between two. Just to understand the indication, remember one thing, that the researchers had maintained a p-value of lesser than 0.005 to indicate significance. So if the p-value of a particular variable is lesser than 0.005, it indicates that it is significantly associated with the main outcome, which is sight-threatening cataracts in our study. And the next thing is confidence interval. So what does confidence interval mean? Confidence interval is stated in percentages. So in case a particular variable has a confidence interval of 95%, that means that if you conduct the study of that variable given number of times, 95% of the times it will be it will result to come in a given acceptable range, and only 5% of the times it will be out of that of an acceptable range. So it basically gives a sense of reliability when you're measuring the effect of a variable. The next is the incidence rate. This is very simple to understand. It just gives the percentage of the population which has suffered, which has come up with the uh, which has come up with a new case of the condition that we are observing within a given period of time. When I explain the statistics, you'll understand. And now the coming to the main thing, which is the hazard ratio. Just understand its implication. The hazard ratio will indicate the probability of a person suffering from visual impairment due to DR-led cataract. Now, this is interesting as this is going to be very useful in understanding the statistics. So, what it is actually used in cases of making survival analysis. So in types of studies, when you are seeing the survival time of a particular patient, and you're viewing at what factors affect the time survival time of a particular uh, individual in that study, and the survival time is that time index date to up to the time of death. So you measure that, but you measure it Yeah. So in hazard ratio, but in our case, what will we do is that we'll see that the number of the main outcome is the occurrence of sight-threatening cataracts, right? So we will see that in how many individuals the sight-threatening cataract is occurring in a given period of time. So it is represented in two ways, either if the value is greater than 1 or lesser than 1. If the value is greater than 1, then it will signify that it will signify that a particular variable is that a particular variable will influence the study group to develop sight threatening cataracts. I will explain it in a much better way in these statistics. Next slide, please. Next slide. One second, please. Yeah. So over here, in this diagram, you can see that I have made a comparison of the variables with respect to made the comparison of the variables with respect to their hazard ratios. If the hazard ratio is greater than 1, then it signifies that there is evidence to prove that uh, these individuals who have these variables will suffer from visual impairment. So looking at the case variables where there is greater than 1 hazard ratio. So people with diabetes mellitus have shown a variable ratio of hazard ratio of greater than 1. The duration of diabetes mellitus from 0 to 5 years has shown that there is greater risk. Patients with acute macular disorders, patients with glaucoma, other retinal diseases that warrant transpass was virectomy. This is a procedure that is done in patients with retinal diseases. The presence of hypertension, other kidney disorders, and the ongoing pharmacotherapy of topical steroids also has a hazard ratio of greater than 1. Uh, and the variables which have a hazard ratio much more greater than 1 are patients who have diabetic retinopathy. So make a comparison of uh, patients with DR and patients with DM. Patients with DR, you can see there are two types of patients: patients who have proliferating diabetic retinopathy and non-proliferating diabetic retinopathy. So you can see in PDR, proliferating diabetic retinopathy, the hazard ratio is 3.9, which is very much higher than 1. So it indicates uh, that patients with PDR and NPDR are very likely to suffer from cataract-related visual impairment. Also, in individuals who range from age 60 to 80, it is really high. And logically, the variables like dementia, allergic disorders, and they are not logically also they have less hazard ratio less than 1, as in they will not be significantly affected by cataract related visual impairment. Next slide, please. This is the table which I have summarized in the last diagram. Can you go 3 slides back, please, Dhruv? Yeah. Over here, we have the table which represents incidence rates. So this is much simpler to understand, and it gives a summary of our main objective. Whether, yeah. So let's take a look. So In a span of 2000 to 2016, we will look at the incidence rate that is written in the third column. So if you see in non-DM control, you have an incidence of 1.41. In DM control, you have an incidence rate of 1.69%, and in patients with diabetic retinopathy, it is 6.47%. That is approximately five folds a risk higher. So this will be summarized in the results that we'll discuss further. Next slide, please. Yeah, in this graph also, if you see, it is plotted the cumulative proportion of cataract percentage. So you can see the first graph which is the steeper graph, shows the patients with diabetic retinopathy, and you can see with the time span how much the patients with diabetic retinopathy are developing sight-threatening cataracts more in comparison to non-DM and DM control groups. Next slide, please. Next. Next. Yeah, so we now come to the main interpretations from the evidences that we saw in the study. So the at the end of the study, 919 events of sight-threatening cataracts had occurred within the patients who had diabetic retinopathy. That means 27.87% of individuals who had diabetic retinopathy at the end of the study developed sight-threatening cataracts. On the other hand, patients with the DM control group developed only 8.4 percentage. Non-DM control developed only 7.26 percentage. Uh, and we also saw that the duration of DM was slightly associated with increased occurrence of DR-led sight-threatening cataracts, as we saw in the Venn diagram over there, as the hazard ratio of duration of diabetes mellitus 0 to 5 years was greater than 1. And we also saw that patients with proliferating diabetic retinopathy had a higher risk of developing sight-threatening cataract. Other risk factors which were included, which had a hazard ratio of greater than 1, uh, also evidence that their presence as variables in people will indicate development of sight-threatening cataracts were hypertension, age 60 to 80, glaucoma, ischemic heart diseases, gout, arthritis, retinal diseases treated with TPVV, uh, and etc. Next slide, please. Now, coming to the discussion, first we'll talk about the main result that we have obtained. Basically, I'm summarizing everything over here. We have now very much evidence to state that DR patients have a very higher risk of developing sight-threatening cataracts in compared to patients with DM control group and non-DM control group. The main pathophysiology which explains the occurrence of this is the hyperglycemia that is occurring in patients with DR, the shifting of glucose into the sorbitol pathway and causing the clouding on the lens, and increased intraocular pressure leading to oxidative stress and inflammation. Um, and we also saw that PDR has a uh, higher risk of developing sight-threatening cataracts. And also we saw a very strong evidence on how older patients with diabetic retinopathy have a higher risk of developing sight-threatening cataracts. And from previous researchers also, this emphasis increases. Uh, then the key risk factors we saw was the uh, the presence of diabetes mellitus with a high duration, other comorbidities, and use of topical steroids, and the age factor also, and the clinical implications. So once this evidence is established that DR patients have a higher risk of developing sight-threatening cataract, clinicians can take into consideration that patients with diabetes with or without diabetic retinopathy should have a continuous and compulsory screening of fundoscopy see to take a visual on whether sight threatening visual impairment is occurring or not. Next slide, please. Now we come to the critical appraisal part, wherein we'll first discuss the strengths of the uh, research that was conducted. First of all, did this research paper have a focused issue? Yes, we had a very clear-cut focused issue, that whether the patients with diabetic retinopathy are more likely to develop uh, sight-threatening cataracts or not. And the next point is, was the cohort recruitment done in a good method? Then yes, the fact that there was a large sample space of a 2 million database was filtered, a good exclusion inclusion objective, uh, okay, exclusion inclusion criteria, uh, and the presence of two control groups gives a very good credit to the study paper. And the exposure measurement, the main outcome that was measured was accurately chosen, which was the need for doing cataract surgeries in the patients, was a good exposure measurement. Um yeah, now coming to the confounding factors, the like discussed in the SLO also, the paper took into account the confounding factor as the presence of diabetes mellitus. So not just diabetic retinopathy, but diabetes mellitus as a control group was also included, which reduces the bias. The follow-up period of the subjects were frequent and long enough in the span of 16 years. Ethically, also, the university made sure, the conducting body of the research paper made sure that the patients who were diagnosed with DMDR, cataracts, and other comorbidities were led to further guidance during and after the uh, conduction of study. Next, please. Now we come to the weaker aspects of the paper, wherein we'll discuss the limitations. So first of all is the generalizability. So in case of any paper, its application to the general public is what is most important, right? So in this case, the study was conducted using the National Health Insurance Research Database of Taiwan. That means that it is very specific to the healthcare system and lifestyle and genetic factors of Taiwan. So considering this study in other countries uh, is a bit questionable. And a limitation that comes as here is again the confounding factors. It Some of it came in the strengths as well, but a confounding factor that we can see here is that HbA1c was not stratified in the DM control and DNDR control group. So you cannot exactly isolate the point that what is the intensity of diabetes that is occurring in the population, and what is its effect on significance on the uh, our main outcome, which is development of sight-threatening cataracts. And also another weakness is there was no involvement of diabetes mellitus other than type 2, which is there is type 1 diabetes mellitus also, there's type 1.5, there is also gestational diabetes and other hyperglycemic physiological and pathological conditions as well could have been included, but they weren't. And the main outcome was the need for doing a cataract surgery, right? It is a subjective criteria and it can depend upon opinions, so it can really create bias in the research paper. So next slide please. Yeah, hello. Yeah, so with that we come to an end of the research paper. I have referred to PubMed Central and BMC Ophthalmology, a department of ophthalmology in Taiwan. They have a website. And with that, I'll come to an end of my presentation. Next slide, please. A special mention to Subarna ma'am and Mumi ma'am for helping me out in interpreting and analyzing the paper. Thank you so much.
Thank you, Dhruv. That was a very informative presentation. I would request Kshitija ma'am to open the Q&A round for Dhruv's presentation.
Yeah, nicely presented by Dhruv. Um, Only one thing I noticed that there was no need of explaining the basic terminologies of statistics here when you are presenting the any article. So it is considered that everybody knows the basic terminologies of statistics. So you could have saved the time. Then I would like to ask one question. Uh, this study is retrospective type of methodologically, and it is based on database. So, what kind of approach in India we will have according to when we think in terms of ethical approval?
Dhruv, can you please unmute? You're muted.
I'm sorry. Uh, Yeah, ma'am. The question of privacy containment, I think, arises when we are looking into people's databases, especially in case of insurance databases. So I think that will come into question when you are looking into a retrospective database.
Yeah, so in India, we need such kinds of study. If we want to conduct, we need ethical approval. I think in this study, they have not taken ethical approval in their country. I suppose they explain that there is no need.
And
And
no, ma'am, they had made an the NHID. Can you show me the authors and information page, Dhruv? Yeah, this page, ma'am, if you see the Taiwan National Health Research Institutes, the Chungshan Medical University, they had made an approach to the uh, Taiwan National Health Research Institutes of whether they can conduct this study and use the longitudinal health insurance database, and the NHIRD had granted them the ethical permission, but they had instructed them to not expose certain informations about the uh, data, as they would have led to privacy containment issues.
okay. Um, then one more question I would like to ask. What are the advantages and disadvantages of this kind of studies, retrospective type of studies?
Um, Ma'am, the first advantage is that you are looking into a database. So you are not being too invasive on the sample size. And also, ma'am, the main application based advantage that we get from this is, for example, in this case, if we produce a significant association between patients who will develop visual impairment if they have diabetic retinopathy or diabetes mellitus, we can create awareness and guidelines to conduct regular screening procedures for patients who have diabetes, into looking into their ocular health. And ma'am, disadvantages of this study would be the same that we just discussed, the privacy issues that come into looking into people's.
I'm asking about retrospective studies. There are lots of biases which occur in such kind of study retrospectively when you see, okay, like information bias or selection bias. Okay, so there are chances. So you can prevent by doing prospective studies. Okay, but sometimes you need that to look into the retrospective way. An
Retrospective
advantage is that it is very much feasible. All the data is available in your hand and you can just analyze it.
analysis, yeah, it is already available data. Yeah.
Yeah, yeah.
Yeah.
Okay, okay, good, good presentation.
Thank you. Any other questions from anyone?
Thank you, ma'am. Now we'll open the floor to questions from the audience. Does anybody have any questions? Yes, Jay. Yeah, Jay, you can unmute.
Hello.
Yeah, Jay, I can hear you.
Yeah. So in the study, they actually mention when they are matching the groups for the potential risk factors, a significant difference was found in the ratio of comorbidities and medication among the groups that were matched. So what they mention is that the use of oral hypoglycemic agents and insulin was
Hmm.
the highest in the DR group, which makes sense, and it
Right.
was much higher than the control group.
Control groups, right.
So does that not mean that basically study the basically the subjected the participants which have been selected already have a much more severe case of diabetes, and so compared to the control group, already the risk of cataract will be much higher.
That's right. That's right. You are absolutely right, Jay. So to explain the other people, I'll tell you that in development of other pathologies in case of diabetes, it goes usually in a flow that first it occurs with neuropathy, then it occurs with nephropathy, and the last is retinopathy, which means that the diabetes has advanced a lot, and the hyperglycemia has been occurred for a long period of time, right? So that again, I have also mentioned that in the weaknesses of the study, that HbA1c was not used for measuring the intensity of the diabetes. Okay. uh, so that could be a reason.
Adding to that, also there is a point in the discussion where they mention that previous studies had done the association, which was one was the duration of diabetes and the other
Mhm.
was the comorbidities. So
Yeah.
I was actually surprised the matching was not done also on the basis of the dosages that are being given.
Yeah. You're absolutely right. The dosage, the treatments that they were on, the pharmacotherapy that they were on to, whether they were insulin dependent, non-insulin dependent, and, and the HbA1c, which should have been included, even that I felt like was a major limitation of the study. You're right. Anything else? Yeah. Yeah.
Just to add on Jay's point about the treatment, like the people with diabetic retinopathy were on insulin and OHAs more. So I think it wouldn't impact the incidence of developing cataract because there hasn't been much evidence to show that insulin itself causes cataract development. So I think that's wouldn't generally be considered a confounding factor, but then it could have been. So it's I think it's in the borderline whether the treatment should have been considered as a confounding factor or not.
Any other questions from the audience? All right. Thank you, Dhruv. We'll move ahead with our next presentation. We have Urvashi Bharia for our next presentation. She's also from first year MBBS and she will be presenting a paper on the trends in central precocious puberty and normal variant puberty.
Good evening, everyone. My name is Urvashi Bharia, and today I will be presenting this paper as Tejaswita has just mentioned. So, basically, we have to start with what exactly is puberty. Puberty marks a dynamic transition from childhood to the mature adult phenotype, and it goes through multiple stages. Some of these stages include adrenarche, telarche, and menarche. Menarche, as everyone knows, is the onset of the first menstrual cycle in girls, and puberty occurs in females at around age 8 to 13 and males 9 to 14. Now, this brings us to what is precocious puberty. The paper is about precocious puberty. So, precocious puberty is the early onset of puberty and sexual characteristics in children. It can be GnRH dependent or GnRH independent. Most of the time in females, it is GnRH dependent and there is no known cause, hence, it is idiopathic. We do not know what causes the central precocious puberty. However, in males, it is generally found that it is caused by neurovascular lesions. So now we come to the various milestones of puberty. At age 8, we have adrenarche, which is the activation of adrenal androgen production. At 9, we have gonadarche, which is the activation of reproductive glands, and this promotes the secretion of FSH and LH. Telarche, which is the onset of breast development. At age 10, we have pubarche, which is the onset of pubic hair growth. And finally, at age 12 to 13, we have menarche. So just let's think, is precocious puberty such a big problem? Because like people have puberty all the time. Every girl has a menstrual cycle. So why is it such a big issue if puberty is coming earlier and earlier? Well, for one thing, earlier puberty can be associated with psychosocial difficulties. The young children can suffer from depression, anxiety, lowered self-confidence. There is also incidence of earlier sexual activity and more risk-taking behavior. It is found there is a relation found between children suffering from CPP and the risk of type 2 diabetes, risk of obesity, cardiovascular disease. There is a higher chance of alcoholism and cigarette smoking, and of course premature death. Further, it has been noted that there is a global decline in fertility rates, and it is possible that it could be linked to CPP incidence increasing. So, which now brings us to the study. What is the objective of the study? The objective is to provide valid epidemiological data on the 20-year secular trend in the incidence rates of CPP and normal variant puberty. Normal variant puberty, that is PT and PA. PT is premature telarche and PA is premature adrenarche. Premature telarche is isolated breast development, but it is also accompanied with the normal growth rate. The bone age corresponds to the normal chronological age, and and it is considered non-pathological. PA, premature adrenarche, is the premature pubic hair development, and again, it follows normal growth rate. So it is also to be noted that this is the first study of its type which we are aware of. Um, We do not know of any other study which has tracked PT and PA. As for ethics, since the study was taken in Denmark, the research goes in accordance with the Declaration of Helsinki. The study was approved by the Danish Data Protection Agency, and by Danish law, we can note that ethical approval and informed consent are not required for these kind of registry-based studies. There is more on that later. I shall explain that. Now the methods. This is a retrospective population-based 20-year cohort study. Most cohort studies are prospective, hence this is slightly unique in that sense. It takes the incident cases of CPP. The population of Denmark is 5.8 million, and in the past 20 years, from 1998, there have only been 8,596 noted cases of CPP, out of which 99.4% are female, that is 7,770. The max diagnostic age limit, according to this study, is 9 years for girls and 10 years for boys. The um, the ICD-10 code, which diagnoses CPP, mentions the maximum diagnostic age limit for girls is 8 years and boys 9 years. However, this study has incorporated a 12-month lag. This lag is to account for the time between the onset of CPP and it being taken to a medical professional and the parents noticing, because you don't always notice it overnight. So you need to give it some time before data can be collected and stored and taken to doctors. Epidemiological studies evaluate the broad rates and trends of diseases in populations, and the major purpose of these kind of studies is to plan public health interventions. This is a cohort study, and it's basically a form of longitudinal study, and it samples people having a defining characteristic, that is, they have CPP. Now we come to the populations of Denmark. Denmark is the prime example for this particular study, as it's a genetically homogeneous Caucasian population, out of which all the Danish citizens are registered in the Danish civil registration system. The DNPR, Danish National Patient Registry, records all the patient level discharges. Every time you go to the doctor, every time you go to the hospital, they take it down. They take down your name, your age, your ICD-10 code, what you're suffering from, etc., and it is all submitted to an online database. So the data has been taken from this database, and it has been accounted for in this study. So, because there could be some form of ethnic diversity in Denmark because of, say, immigration, we have divided the population into three major ethnic groups. We have children of Danish origin who are they are born in Denmark to parents who are also born in Denmark and have Danish citizenship. Second generation immigrants are children who are born in Denmark, however, their parents are not born in Denmark and are not Danish. First generation immigrants are children who are not born in Denmark who are also the children of parents who are not born in Denmark. So basically, we have divided them into the possibility of having other genes from other races of humans. So the exclusion criteria for this is immigrant families. These immigrant families might have only been in Denmark for a short period. So, and because they're only here until asylum is granted, so they are not even part of the DNPR. Hence, they are automatically excluded. Now the statistical analysis. We have the crude distribution on the basis of sex, male and female, immigration status, Danish origin, second generation immigrant, first generation immigrant, and diagnostic subgroups CPP, PT, and PA. The mean incidences of each disorder are estimated over 20 years and over 5-year subgroups, so that we can identify the rate of progression of incidence. The data is visualized as a function of the calendar year. Now we have the results. I would like you to just look at this for a few minutes. Here we can see the incidence rates of central precocious puberty. It has a 95% confidence interval. A 95% confidence interval means that if the study is repeated n number of times, there is a 95% chance that we will get the same result. So here we have the rates, the incidence rates for girls and incidence rates for boys. Please note that the 20-year mean incidence of CPP and PA among girls in the first generation and second generation immigrant groups are higher than that of Danish origin. This over here 13.7 is for first generation and 14.2 is for second generation. It is 13.7 per every 10,000 of population. Now we come to graphs. The annual incidence amongst girls of Danish origin. We have noted a six-fold yearly increase in CPP in the past 20 years. In 1998, it was 2.4 per every 10,000 population. In 2018, it was 14.4 per every 10,000 population. Further, there is a 33-fold increase in PT and 18-fold increase in PA. Now we have the total incident cases for boys. It is to be noted that for boys with Danish origin, the incidence of CPP was much lower. It was 0.9 per every 10,000 population. Also, there is not much difference between the incident rates of between Danish origin, first generation, and second generation boys. Now we come to the age-specific mean incidence amongst girls of Danish origin. Here we can see that for central precocious puberty, most girls who have been diagnosed with this disease are diagnosed at age 8 years. For premature telarchy, the mean incidence occurs at ages 0 to 2, which corresponds with mini puberty. Premature adrenarchy occurs at ages 7 to 8 years in girls of Danish origin. Now we come to interpretation of the data. Out of the total of 8,596 children, 90.4%, that is 7,770, were girls. The median age at diagnosis for boys was 8 years and for girls was also 8 years. There has been the incidence rate is 430 new cases per year in Denmark. Most children who were diagnosed with this disease were of Danish origin. That is, 86% of all cases belong to children of Danish origin. Incidence of CPP was ninefold higher among girls of Danish origin compared to boys of Danish origin. And the 20-year mean incidence of CPP and PA among girls in the first generation and second generation groups is way higher than that of girls of Danish origin. Further, there has been a steady increase in CPP rates as observed for all children of Danish origin. Now we come to some graphs. Here we can note that the prevalence of CPP is higher in girls. Here we have the incidence of CPP amongst children. The incident cases amongst children of Danish origin is 86%. That is 7,391. Out of this 7,391, girls make up 90.3% of the incidences. That is, girls of Danish origin are 6,671 out of 8,596 cases. Now we come to a quick summary of all the results. The 20-year mean annual incidence in girls with Danish origin. For CPP, it is 9.2 per every 10,000 of the same population. PT is 1.1 and PA is 1.3. For Danish boys, CPP incidence rates are 0.9 and PA 0.2. It is to be noted here that boys are not applicable for PT, premature telarchy, since they do not have breast development as part of their puberty. The 20-year mean incidence of CPP and PA among girls in immigrant groups is higher than that of Danish origin girls. In first generation, CPP rates are 13.7 and PA rates are 2.0. In second generation, CPP rates are 14.2 and PA is 1.5. It is also to be noted that the annual incidence of telarchy was similar amongst all girls, and there is no marked difference between immigrant groups of boys. And also, as I mentioned earlier, the study has a 95% confidence interval, and the confidence interval of CPP is 8 to 10.3 per every 10,000 population. Incidence of CPP and PA amongst girls. Here we have the same data that I had explained over here. We have the rates. Here I have just visualized it better so that you can understand the differences. First, we have Danish origin girls, second generation girls, and then first generation girls. Thus, we can say that girls of Danish origin they have a much less prevalence rate of CPP and PA. Now comes to the discussion. We've got all this data, but what does this data mean? What do we do with the rates of CPP and PA and PT and all that? We have noticed now that there is a substantial upward trend in the annual incidence of CPP and normal variant puberty. So that brings us to the question, is it possible that the current ICD-10 codes are just outdated? Because if you're having these kind of rates are rising, if you're having this all over the world, then is it possible then that humans are just attaining puberty earlier? So, if this is indeed the case, we need to there needs to be a drastic revision of ICD-10 parameters, because the current parameters for CPP, PT, and PA were set in 1950. The premature sexual development in younger girls is associated with adverse implications for long-term health. As I mentioned earlier, there is increased rate of reproductive cancer. There's depression, anxiety, suicide rates, etc. The onset of puberty across populations without any clear indication for the underlying mechanism, this could be a worrying case because we don't know what's causing it. And of course, possible false diagnosis of precocious puberty, which could be what the first point mentioned. It's possible that everyone is just attaining puberty earlier. So if that is indeed the case, then all these diagnoses of PP could be wrong. And this could lead to psychosocial implications, unjustified hospitalization, unnecessary MRIs, and hormonal treatment. Now, factors affecting the timing of puberty. These could also be like these days we have a lot of extra stuff. We have these, what do you call them? Yeah, we have genetically modified food. We have cell phones, radiation. All this could be possibly causing puberty to come earlier. So, what exactly are the factors? We have hereditary factors, which can be on the basis of ethnic groups. We have childhood obesity. However, there was a study done in Denmark around the same time, a study which tried to correlate central precocious puberty and BMI. While it has been noted that the BMI rates have been increasing steadily over the past 20 years, there does not seem to be much of a link between increased childhood obesity and increased incidence rates of CPP. As for pre and postnatal exposures to endocrine disruptors, a French study was taken where it was noted that the CPP rates in agricultural areas was higher than that of urban areas. So it is possible that there is something in these agricultural societies which is causing CPP to come earlier. Of course, there is early childhood nutrition and international adoption and physical activity. A contemporary Korean study came to similar conclusions, where the mean incidence of CPP was indeed coming higher than usual. Uh, it was coming higher than it's coming higher than the Danish study. However, the inclusion criteria for this was not the same, and it is possible that the Korean study. It is possible that because of genetic differences, Koreans are just more prone to CPP as opposed to Danish people. Now it comes to the further implications, like what does the study mean? Again, so if indeed that central precocious puberty is coming earlier, then we need to have preventive health measures. There should be screening programs for CPP. There should be the people should build more awareness amongst the parents, the doctors. There should be more social outreach programs at the grassroots level. And if there is an international shift in reference ranges for puberty, then there should be a similar shift in the diagnostic criteria in the ICD-10, which can reflect this change. So I've now come to the summary of the paper. I would like you to read this for a minute or two, and then I will continue with the critical appraisal. So this paper has got several strengths. The study addresses a clearly focused issue in the incidence of precocious puberty in populations. Because of the genetically homogeneous population, there is minimal bias. and the cohort was recruited by the DNPR. Thus, it covers all socio-economic strata. Denmark having free and high quality healthcare. This ensures that people of all social backgrounds, socio-economic backgrounds, they come to get treatment, and all of their cases are noted down and submitted to the database. This paper is the first study to report incidence of PT and PA, and this being an epidemiological study, it follows the population for 20 years, which is a substantial time to account for incidence rates of CPP. Further, as I mentioned in the beginning of the presentation, as for ethics, the ethical approval and informed consent are not required for this kind of registry-based epidemiological study, as the DNPR database is public domain. Further implications of this study could include possible revision of diagnostic criteria to keep pace with the global trends. Further, the results of this study were consistent with other similar studies across ethnicities. There was a Korean study done and there was a Spanish study done. This indicates that there could be a global increase in incidence rates of CPP. Growing parental awareness of and concerns regarding earlier puberty due to media coverage and grassroots level outreach programs. This may have increased the number of children who have been diagnosed with CPP, because if the parent doesn't know that this is an issue, then the parent wouldn't take them to the doctor, and hence those cases could be completely missed out. And to adjust for confounding factors, population is stratified into three ethnic groups: children of Danish origin, first generation immigrants, and second generation immigrants. However, there are several weaknesses which I have identified. The study may have not accounted for several confounding factors. It's not known to what degree the patients with registration in the ICD 10 have met all the diagnostic criteria. There could be human error. The initial diagnosis coding may not have been updated. Like, for instance, if a child has come to meet a pediatrician with possible diagnosis of CPP, the code will be inputted into the DNPR. However, upon proper clinical examination and diagnosis, it's possible that the child does not suffer from CPP, and the doctor must have forgotten to just update the DNPR. So it is possible that that such cases could occur. Further, we are unable to identify children who are adopted. However, I personally feel that I don't think this is much of an issue, because only 0.8% of Danish children are internationally adopted. There are also cases where the parent did not see precocious puberty as a condition that warrants clinical diagnosis. This could be due to lack of awareness. And of course, there is the possible effect of mass food production and hormonal disruptors, which have not been accounted for in the study. And lastly, there could be environmental factors. There could be something in the Danish environment, maybe something in the child rearing cultural practices of Denmark, which could be accounting for this CPP, but we have no idea. And thank you for your time, and I hope you understood this presentation.
Thank you, Urvashi. That was a very engaging presentation. I would request Kshitija ma'am to open the Q&A round for this presentation.
Yes, Urvashi, nice presentation, good
Thank you,
article
ma'am.
selection. My question, only one question is that is this study findings can be extrapolated for changing international reference classification?
Ma'am, I personally feel that this study it can be extrapolated for white Caucasian populations with minimal genetic intermixing. As for international populations with large immigrant groups, I do not think this is a suitable study, and more data has to be collected across different countries.
Yes. So for extrapolating such kinds of data, we need multicentric international studies, and then collectively you can change the international reference values. No.
Yes, ma'am.
Yeah. Good. Good presentation.
Does anybody from the audience have any questions? Yes, Rudra. Rudra, we can't hear you. I think there's some problem from your side. Okay. Any questions? All right. Okay, Mrunal, please.
Hi Urvashi, I would like to ask that on what basis was the age determined, like 8 to 13 for females and 9 to 14 for males? Like on what basis this was uh, considered?
Basically, 8 to 13 for females and 9 to 14 for males is that is the age for normal puberty, and it has been these are the ICD-10, the International Code of Diseases. These are the diagnostic criteria for normal puberty. So this has probably been taken by a previous retrospective cohort study, which could have been taken over several years. And so basically, this is the normal age for puberty, according to several studies. And the in European countries, they take the ICD-10. So when you go to a doctor for and if they diagnose you with something, so they will reference this before informing you of their diagnosis.
Okay, all right. Thank you.
Yes, Rudra.
Yes.
Rudra, we can't hear you. I think there's some problem, internet problem. Smith.
Yeah, so I had one question. So you said that the study can be extrapolated to populations having like homogeneous genetic this. But according to one finding in the paper, it has said that the mean incidence of CPP was higher in first and second generation people. So that means there is some level of genetic mixing, and those people are specifically having higher incidence than those of Danish origin. So I feel like these 2 points are conflicting, that it should be applied to homogeneous populations while the genetically mixed ones are having a higher incidence.
As for That's actually a good question. Basically, the genetically homogeneous population, the children of Danish origin are more likely to be genetically homogeneous as opposed to children of immigrants. So it is noted that they have a lower incidence rate of CPP, and so it is possible that's why I personally feel that these results can only be extrapolated to white Caucasian populations. We don't know what race and ethnicity these immigrants are, hence we cannot comment on that.
Okay, thank you. So would you say that the environment is more influencing than the genetics?
um I would say that actually the genetics is more influential than environment, because as there was a Spanish study done, and the Spanish study was getting similar incidence rates, and socio-economically Spain and Denmark are on par as opposed to Korea, because in the South Korean study had measured in substantially higher levels of CPP. And also we have to take into account the immigrant populations, seeing how the immigrant populations and the Korean population, hence the non-white populations, have higher incidence rates. It is possible that the it's possible that genetics has a higher role to play than environment.
Okay, thank you.
Regarding the point about first generation immigrants having a higher incidence rate, could it also be simply a function that the population that is being surveyed of uh, first generation immigrants is much lower than those of the Danish origin? So because I think they have like 5,000 cases for the Danish and like around 700. So the difference in the percentage might just be because uh, the sample size is not enough to extrapolate.
But we're taking incident rates. The incident rate is taken as a ratio of every 10,000 population. Right. So, like, I didn't really understand your question. Could you just repeat that, please?
No, so I was wondering was that the first generation population by itself is much lower in Denmark as compared to as compared to the Danish ones, right? So
Uh, I can't really hear you. Your voice is cracking. Could you just repeat that? Like, I heard the first part. I didn't hear the second part.
so the annual population of the first generation immigrants might themselves be much lower, and even their socioeconomic status might be much different. They might be refugees. So even those categories could be a much bigger factor than the genetics.
That is possible. The socio-economic factors could be they could cause increased rates of CPP. Uh, the South Korean study, it had similar results. In the South Korean study, the socio-economic strata would be similar to the immigrant strata in theory. They have not provided data as to what the socio-economic levels of of each ethnic group is. So I cannot comment on this. I cannot confidently comment on this, but that is a possible cause.
Does the appearance of these trends actually require a shift in the disease classification in puberty? Can it not just mean the incidence of CPP is that is a pathology has increased, and it doesn't necessarily mean that this incidence or this trend has become physiological. So does it really require a shift in disease classification?
If we have noted a worldwide increase in incidence rates, then it is possible that humans are constantly evolving. The puberty age, like 100 years ago, was much higher than the puberty age right now. So everything is coming earlier and earlier. So it is possible that it could be possible that this is just some kind of what do you call it? Some kind of evolution which is going on slowly, or it is also possible that this is it's just pathological. But since we do not know for sure, as this particular topic has not been studied very intently, we do not know for sure whether it's physiological or pathological. Hence we just need to give the benefit of doubt, because if we are seeing that it's happening worldwide, then and it's happening worldwide across ethnic groups and across socioeconomic strata, it's possible that this is just something which is happening to humans globally. And if that is indeed the case, then we need to revise the ICD-10 codes.
But you did just talk about how this study or the ones you've mentioned can be extrapolated only to white Caucasian males. So, is it actually happening worldwide?
Yes, we have a Korean study, which was admittedly the exclusion criteria are different, and that was taken by an insurance company data. So it is, but if we read the results of the study, there has been a similar increase in incidence rates of CPP. It's just that in Korea, the incident rates are much higher. So, and in the Spanish study, which has been referenced in the article, there has been a similar increase in incidence rates. In the French study, there has also been a similar increase in incidence rates. But basically, since these studies are all very different, we cannot clearly say if yes, this is the cause, because they all have got different exclusion criteria.
Yes, Dhruv.
Uh, Hi, I just like to say I think it's important to note that this study, if you look at the title, it's just mainly trying to highlight and document the trend, that the trend in CB. It's not exactly establishing a cause. So when you ask, should we, like Rudra was saying, should we really actually change the definition of CPP or precocious puberty? What matters more is is precocious puberty, how much of effect is it having on the patient's life? How much of effect is it having on their mortality, morbidity, on their quality of life? Because if there is no issue at all, then it's all good, well and good to say it's physiological. But if it is due to some pathological cause, or if it's causing issues like uh, increased high risk activity, shorter stature, and lower life expectancy, then it'd be a pathological. It'd be you'd want to call it pathological. And I think it's important to highlight this study is not trying to establish the cause. It's trying to document that
There
this
is
is a
need of
trend.
such more studies
Yeah,
for
it's like a
evidence.
it
We
raises
need some
awareness.
evidence whether it is pathological or
Yeah.
will it have any implications. Okay, so more studies are needed.
Yeah, we
Yes,
Like
ma'am,
need
that is
definitely
correct.
more studies regarding the effect on the patients itself, because this does not talk about what effects are happening to the patients who were diagnosed with precocious puberty. What effect did it have on their life?
I
Um,
completely agree with Dhruv here. I think like the similar parallel to draw here is that the incidence of diabetes is increasing all over the world. So that doesn't mean that you necessarily need to say that a sugar of 140 or 150 is will now be considered normal. It all depends on what complications it will cause. Like a sugar of 140 will cause more complications than a sugar of 110. So then, as ma'am also said, I think this needs further studies to be done. This is just giving us a small look into what is happening in Denmark.
we also have to note that there has been an increase of incidence in normal variant puberty, PT and PA. So, since this study has not been taken by anyone else before, it's a pilot study. It's possible that the data could be confined to Denmark itself. But between 1998 and 2017, as I mentioned in the data, there has been an increase in normal variant puberty as well. I'll just pull out the slide. Yeah, for annual incidence amongst girls of Danish origin, there has been a 33-fold increase in PT and an 18-fold increase in PA. Since these are considered non-pathological, so I do not know if this requires or even warrants a change in the ICD-10 codes. But it is seen that there has been an increase in the incidence rates of early puberty. Does anyone else have any questions?
Any other questions from the audience? Okay, so I guess that's it. Thank you, Urvashi.
Thank you so much.
With all the presenters done, we will be concluding this meeting. I would like to thank Kshitija ma'am for her valuable time and insightful contribution to this meeting. I would also like to thank all the participants and my journal club team for making this event possible. Also, very special thanks to the PR team and the tech team, uh, without whom running this meeting seamlessly would have been not possible.